contraindication because we are putting a cannula which can lead to bacteremia. The foreign membrane is there, which will again aggravate the inflammatory responses, and further, if the patient is having sepsis, that will be further a problem. And in the sepsis, there may be a pre-existing coagulopathy, and that may lead to a bleeding complications. But in the 1990, several studies shows that ECMO may be helpful in the cases of sepsis. And nowadays, VA ECMO and VV ECMO both actually we are using in the cases of sepsis. But VV is reserved only for the patient who are hemodynamically stable and possibly they have the lung issues. So if you look at the trend that how it changed from 1970, in the 1970 grossly, if you look at the neonatal, pediatric and adult data, so it was thought that it is contraindicated. In 1990, possibly UK collaborative group said that they showed a good survival of nearly 80%. And while in adult, it was suggested that it cannot be used as a, should not be used because of the poor outcome. But now gradually the various trials and the ELSO data, which all have shown that it can be used safely. And this is the data from the ELSO as well. And by ELSO, the sepsis is defined as the presence of the pathogenic microorganism. Are there toxin in the blood? Are the other tissues? It may be diagnosed clinically by the symptomatic evidences of infection or by the laboratory confirmation. It may also be diagnosed by a positive culture as well. And ELSO consider a criteria survival on sepsis is a successful separation from the ECMO itself. If you look at the sepsis, it is basically a shock is a life-threatening acute circulatory failure with the inadequate oxygenation, oxygen utilization by the tissues. Septic shock with the most severe manifestations of sepsis, which where the mortality is as high as 40 to 50% and can go up to 80% depending upon how many organs are involved. And usually what we found in the multi-organ dysfunction, we all know vasoplegia, there can be acute kidney injury, ARDS, DIC, cardiomyopathy, cerebral failure, rhabdomyolysis, hepatic dysfunction. So all possible things can happen. So what exactly happens? There is a pro-inflammatory response. Yesterday, Ram was talking pro-inflammatory and anti-inflammatory response. And basically it is the effect of the host response to the infection, how the body is responding towards the infection, and that all depends. Pathogenic factor, how much is the load, what is the virulence of the organism, and what is the molecular pattern. While the host factor will involve the environment, what is the age of the patient, what are the other comorbidities. And ultimately what it leads to, there is a tissue hypoperfusion, there is a vasodilatation because of hypotension, decreased rest cell deformability, and this tissue hypoperfusion, along with that, there is a disruption, loss of the barrier functions. So there is a lot of fluid shift and compromised tissue oxygenation. So all these leads to a state of septic shock. What happens to the myocardium? If you look at in the early phase, basically it's a low flow state because there is a lot of fluid shift in the third space, so there's a relative hypovolemia. If we give fluid at this stage, the cardiac output will improve and the perfusion improves. But in the second phase of the hyperdynamic circulatory state, there's a high cardiac output. But in spite of high cardiac output, along with the low systemic vascular resistance, still tissue perfusion is not sufficient. And in the last third phase, what exactly happens? The cardiac output ultimately starts falling. There is an increased systemic vascular resistance, and this compromised tissue perfusion leads to metabolic and lactic acidosis. So if you look at this diagram, if you look in the initially, the stroke volume, you see that stroke volume is 50%, the acute phase of the septic shock. And if we calculate the ejection fraction, so we see that it is a 25% because the end diastolic volume is 150. It is not hardly ejecting any blood. But once patient reaches to the recovery phase, this improves because now the end diastolic volume has decreased and the ejection fraction has improved because there is a myocardial contractility has improved. So what we see, all kinds of a myocardial dysfunction, LV systolic diastolic dysfunction, usually in almost 50% of cases. So basically LV compliance is impaired with a slight LV dilatation. Then gradually patient develops a systolic dysfunction. By day 3, there is afterload sensitive and may develop a RV systolic dysfunction as well. And it can be isolated or it can be associated with a acute lung injury or ARDS. So how the manifestations are? It is different in the newborn. If you look at, it's a persistent pulmonary hypertension of the newborn with the right ventricular failure. While in infant, you will see that there is a impairment of the LV function with a low cardiac output state. While in adult, we'll find that there is a distributive shock or vasoplegic shock and is often associated with a high cardiac output in spite of poor tissue perfusion. So how the ECMO is going to help in cases of sepsis? It can support temporarily for the cardiovascular system. It can support the lung, and definitely once it improves the oxygenation and maintains the hemodynamics, if it's a VA ECMO, then it can temporarily support the kidney as well by improving the perfusion. It will dilute the cytokines, and it can be used as a platform for other supportive therapy. However, this other supportive therapy, how much it will be useful is still a matter of debate. So we should be clear that it is not a treatment of sepsis. We are just supporting temporarily as we do for other conditions as well. So veno-venous ECMO, it is going to provide oxygen and will remove the carbon dioxide because this is an issue because of the severe lung dysfunction. Peripheral VE ECMO, which can provide the circulatory support and will help for the gas transfer as well up to a certain extent. And central ECMO, which can provide the circulatory and respiratory support, but this will need sternotomy, and we can understand very well that how much complication can occur because the patient is having already septic shock patient, along with that having some coagulation abnormality as well. So the two important manifestations where ECMO can be helpful. One, if the patient, because of sepsis, patient has developed severe ARDS and is not able to maintain his oxygenation even with the high ventilatory parameters. And the second is septic shock, where the patient is hemodynamically unstable in spite of appropriate fluid resuscitation and using the high vasoactive substances. So which type of ECMO? This is important to choose. A patient with a septic shock with a high dose of NORAD or epinephrine, we do an echo, and on the basis of echo, we look at what is the status of RV. If there is a RV failure along with the ARDS, we initiate with the VV ECMO. We try to stabilize the pH, we improve oxygenation, and we can reduce the ventilatory peak inspiratory pressure so that we can improve the hemodynamics as well. But if the RV failure is still persisting, then definitely this VV ECMO can be switched over to the VVA ECMO. The other thing can be the LV failure. We look at the ECG, TROP-T, and we confirm it. We do the peripheral VA ECMO. But in due course, if the patient is developing a severe ARDS, we can switch over to the VAV ECMO. And if the patient is having a normal ejection fraction, or even if the patient is having hyperkinesia, then possibly ECMO cannot be a good option. However, we can think of central cannulation to achieve a very high amount of flow, because to match the flow required for this support during this septic shock will be much, much higher, which is beyond for the peripheral VA ECMO. So what's the advantage of VA ECMO? It provides the cardiac and respiratory support both, decreases the right ventricular preload, no risk of recirculation, and better oxygen delivery. However, it is going to increase the afterload, pulse pressure may be narrow, coronary oxygenation with the left side of the blood, so you have to be very, very careful. In due course, if the patient is developing ARDS, you have to manage. There is a risk of cardiac stunning and definitely decreased cerebral autoregulation. VV ECMO, it can avoid the major arterial issues. It can give directly the pulmonary improve the pulmonary oxygenation, and there is no issue related with the coronary oxygenation or any neurological issues related with the perfusion. Maintains the patient's cardiac output and pulsatility. Vasopressors is not a contraindication, provided it's not very high. Disadvantage, may have the inadequate oxygen delivery, may not achieve that amount of the flow is required, does not provide direct any cardiac support, and there is increased incidence of recirculation, then probably oxygenation will be an issue. In neonatal, it is a accepted therapy in a variety of conditions, including the sepsis. Survival is as high as 80%, when whether the indication is respiratory or for the circulatory failure. VA cannulation is preferred in the neonatal population, and VV ECMO with single cannula is becoming popular, but is still VA is a preferred one. So if you look at this, the guidelines of the American College of Critical Care Medicine, even they have included for the refractory shock the use of ECMO. In the children with the sepsis, it's still controversial as compared to the infant and neonatal population, because of the lower survival rate related with the irreversible nature of many illnesses in this age group. So again, as per the American College of Critical Care Medicine recommendation, it can be, if the persistent catecholamine resistant shock, refractory shock, then we can think of doing ECMO in these patients. In adult, because poor outcome was in the past, however, the recent literature is encouraging, but still we do not have a very large trial on this to show that yes, it is definitely beneficial. If you look at this paper, where they compared the survival of the septic patient with the non-septic patients, and they recommended that the pre-existing sepsis is not a contraindication for ECMO. However, for doing a VA ECMO, it should be used with caution given active, if the patient is having active sepsis, because what they found that the outcome was better with the patient with the who had the non-sepsis. However, the septic patient had a survival of 24.4% only. This was another paper where they did VA ECMO for all 14 patients with maintaining a blood flow rate of around 4 to 5 liter, and they have shown a very good survival of nearly 71%. All these patients who had the shock before starting of ECMO, and the time interval was average was 24%, and they had the ejection fraction of average 16%, no cardiac arrest before ECMO, and all patient had the low cardiac index and the profound myocardial depression with the elevated systemic vascular resistance. And they did not found, and the survivor and non-survivor, not much of the difference, but they found a good survivor of 71%. So if you look at the literature, multiple papers, these are the neonatal data. If you look at nearly survival 100%, 72%, mixed population 56%. But if you look at the adult data, in the gram-negative sepsis, it was found that survival was just 15%. But this paper has shown the survival of 71%, and the results are encouraging. How do we do the cannulation? So no issues if we have the ARDS related with the sepsis, veno-venous, excellent, because we are maintaining oxygenation. And as soon as we start improve the oxygenation is improved, hemodynamics itself starts improving. If patient is having a myocarditis, then veno-arterial ECMO. But issue is how much flow is required. Are we able to match with the peripheral VA ECMO? In those conditions, possibly if we need a very high flow, then we can use the central VA ECMO. And if patient is having both ARDS as well as patient is having a myocardial dysfunction, then possibly VAV will be an option. So this is the ECMO cannulation strategy in the septic shock patient. If the patient is having a right heart failure, and the usual patients are the neonate, so cannulation option is VV ECMO, which will avoid any risk of systemic embolization, and peripheral VA ECMO using the carotid and internal jugular, or we can go for the central VA ECMO. Usually they have the low cardiac output and high SVR. If there is a left heart failure, usual population is the young child, peripheral VA ECMO using a carotid and femoral. But if it is the distributive shock or usually mixed shock, so usual population is the child or adult population, central VA ECMO or peripheral VA ECMO depending upon how much flow is needed. These patients are usually having the high cardiac output and low systemic vascular resistance. So advantage of central cannulation, achieve high flow rate to provide a quicker resolution of the refractory shock. We can go up to a flow of 10 liters per minute without any maldistribution of the oxygen. So no issues of the Nassau syndrome. And there is a complete cardiovascular support. However, we should always keep in mind that we are going to do a sternotomy and patient is still maybe having some coagulation abnormality as well. So these are the suggested cannula size for doing the central VA ECMO. But still there are several unanswered questions. any particular pathophysiology pattern which can be beneficial, where the ECMO will be beneficial, superior to other one. Combining ECMO with the other adjuvant therapy like a plasmapheresis or using the plasma adsorptions or IVIG, whether it's a beneficial or not. How much ECMO flow is required? So is central VECMO maybe better? How much should be the anticoagulation? Because the patient is in the DIC, maybe in the DIC. Oxygenated membrane and tubing polarization issue, because patient is already having sepsis. So can it be a focus for sepsis after few days? And how ECMO and other modality can affect the vasculature and tissue level of oxygen kinetics. So to conclude, ECMO can improve survival in the septic shock, but we have to choose the patient judiciously. Septic patients with predominantly the cardiac dysfunction may get more benefited. No universally accepted criteria to initiate the ECMO. Fundamentally, if the tissue oxygen delivery cannot be maintained despite optimal ventilation, inotropes and intravenous fluids, then probably ECMO should be considered. And central cannulation may be better theoretically to achieve a higher flow, but how much it will be beneficial is still doubtful. Thank you very much. Any question?